This podcast is going to be concerned with the theory of unpleasant symptoms by Lenz and colleagues. It is a middle-range theory of which we're going to be discussing several in this class. The purpose of the theory is to explore the commonalities and symptoms across different clinical populations. And I have a quote from Lenz and Pugh. The purpose of the theory is to improve understanding of the symptom experience in various contexts and to provide information useful for designing effective means to prevent or ameliorate unpleasant symptoms and their negative effects, unquote. And that's from the Middle Range Theory for Nursing by Smith and Lear in 2003. The model is useful for research since the results of numerous studies can be combined and become a basis for the use in practice. The theory of unpleasant symptoms, although explaining what is happening at the individual level, takes into account all of the factors that affect the person experiencing unpleasant symptoms, including the context of the experience, such as the position in the family, community, etc. We're going to be discussing the concepts of the theory, which include symptoms, influencing factors, and performance outcomes. And we're going to look at each of these in depth. Central to the concept of the theory of unpleasant symptoms is symptoms. And we're going to look at the definition of symptoms, and we're going to look at the different dimensions, which are intensity, distress, timing, and quality. Now, defined by Rhodes and Watson in 1987, symptoms are, quote, the perceived indicators of change in normal functioning as experienced by patients, unquote. In the updated version of the theory, Lenz and colleagues described it as the red flags of threats to health. This means that only the person who is experiencing the symptom can know and describe it, much like when we as nurses say that pain is what the person says it is. Symptoms can occur in isolation, but can also occur in clusters, and when they do occur in clusters, they tend to be synergistic, meaning that if a patient has postoperative pain, that any dyspnea associated with the procedure may be perceived as worse than if perceived as the only symptom. Now, intensity is the degree, strength, or severity of the symptom. It is the most frequently measured, and as you know, we use the visual analog scale when we look at pain. Now, distress is the degree to which the person is bothered by the symptom. It varies from person to person and situation to situation. For example, as Lenz and Pugh described, nausea for a woman who has had difficulty conceiving is very different than nausea from a patient who is receiving chemotherapy. One may find the symptom life-affirming, while the other is reminded of her mortality. The degree of distress is usually related to the intensity of the symptom. For example, the higher on the pain scale, the more the distress. Now, timing is explained in the update to the theory in 1997, and Lenz and Pugh said, quote, the time dimension includes the frequency with which an intermittent symptom occurs, the duration of a persistent symptom, or a combination of frequency and duration in symptoms that are intermittent but persist over long periods of time, or that are chronic but vary in intensity. Now, quality is what the symptom feels like. It is usually specific to a certain symptom, such as pain being burning, stabbing, or dull, or in the case of dyspnea, suffocating or not getting enough air. Influencing factors are physiologic, psychological, and situational. Physiologic include the anatomical, physiological, or genetic variables influencing the symptom. For example, to name a few, inflammation, energy levels, nutrition and hydration, or age. Symptoms are indicators that pathology exists, so there is a reciprocal relationship between physiologic factors and symptoms. Inflammation is usually accompanied by the symptom of pain from the release of bradykinin. The psychological factors are the affective and cognitive variables. The affective state is the mood, for example, depression or anxiety, that can heighten the symptom. The cognitive state includes the individual's level of knowledge about the symptom or disease state. It also includes coping skills. From research, there is physiology in mood states, and therefore the psychological and physiological factors may be difficult to separate. Now, the situational not only includes the influence of culture and physical environment, but also such things as socioeconomics, marital status, access to health care, and lifestyle. Culture teaches one about the meaning of symptoms. In my own culture, they taught me to be very stoic and to first rise above the symptoms. The physical environment can heighten or diminish the experience of symptoms. For example, going out into a cold rain can make the symptoms of an upper respiratory infection feel much worse. Access to health care can also influence the symptoms. If a person is not covered by, let's say, health insurance, and they get a symptom, they may focus on the symptom, and the symptoms become much more than they really are. Performance outcomes are the consequences of the symptom experience. They impact the manner in which people function in life. For example, being able to carry out ADLs or IADLs, and can have proximal as well as distal impacts. Performance outcomes also have several dimensions, including cognition, comprehension, learning, concentration, social interaction, and problem solving. If a nurse cannot stand on his or her feet for more than 15 to 20 minutes, it will impact the ability to perform as a nurse on a telemetry unit. That's a proximal outcome. A distal result would be a possible home foreclosure because of losing the nursing job and being unable to make the mortgage payments. Now, this is the model, and the model expresses the reciprocal nature of the symptoms, influencing factors, and the performance outcome. And I'm going to make several statements about the model. The first statement is, the symptoms, when clustered together, are synergistic, and the intensity, distress, timing, and quality of one symptom is interrelated with other symptoms. For example, a person with an arthritic knee suffers from an aching pain that causes much distress when climbing stairs. If he also suffers from dyspnea related to COPD, the pain may be heightened because of the shortness of breath when climbing stairs. The dyspnea will more than likely be worse because of the pain. A second statement. The physiologic factors, psychologic factors, and situational factors also influence the symptoms. For example, using our person with the arthritic knee, if he has a flare-up of pain, it is more than likely related to a narrowing of the space in the joint capsule and possible release of more bradykinin. If the patient has also experienced a recent loss of a loved one, there may be some depression and anxiety which would heighten the experience of pain. Lack of social support may lead to focusing on the pain because of lack of a pleasurable distraction and thus increase the symptom. The influencing factors, physiologic, psychologic, and situational, are also affected by the symptoms. Experiencing pain may lead to decreased use of the joint, which results in more damage. Pain that is not relieved can exacerbate depression. Social isolation may occur if the person becomes grumpy because of the pain. For example, no one wants to visit. The third statement. The symptoms also proximally and distally affect performance outcomes. Pain in a knee joint may preclude the patient from being gainfully employed, which may cause him to lose his health benefits and then being unable to access health care. Statement 4. Performance outcomes affect the symptoms. A man with knee pain who is out of work may not be able to see the primary provider who prescribes medication and physical therapy for the pain. Therefore, the pain is exacerbated. And finally, performance outcomes also affect the influencing factors. If our patient with the knee pain cannot work, he may suffer depression, lose his home, and may have to move out of a residence that is more difficult to carry out ADLs, for example, more stairs. And if he is inactive because of the job loss, the joint will not actively repair itself. Now, as usual, I'm going to ask you to go to YouTube and please view Lenz's theory of unpleasant symptoms. And I hope this little podcast has provided you with clarification on this middle range theory.